Today's concept is sexuality. It's the physiological, psychological, and sociocultural aspects of human sexual behavior and preferences, including the processes of conception, gestation, and childbirth, through coordination efforts of the intact reproductive, endocrine, and psychological systems. Today's exemplar is infertility. So to start, we have to go over some basic terminology. Infertility means that it has taken a prolonged time to conceive and has been so far unsuccessful. Sterility is the inability to conceive. Primary infertility is the difficulty conceiving when there has never been a pregnancy. Secondary infertility is difficulty conceiving after having had a pregnancy, regardless of the outcome. Female infertility causes. So there are hormonal and ovulatory factors. Primary anovulation may be caused by a pituitary or hypothalamic hormone disorder, usually seen in adolescents. Secondary anovulation is usually seen in young to midlife women. Okay. Ovulatory dysfunction is another cause. Risk factors for ovulatory dysfunction include aging, obesity, polycystic ovarian syndrome, also known as PCOS, strenuous exercise, or endocrine dysfunction. Next cause is early menopause that may run in families and considered to be before the age of 40. In menopause, the ovaries do not respond to ovulation-inducing drugs. Also, nutritional conditions such as eating disorders, very low weight, or poor diet can disrupt ovarian function. Cancer treatments involving ovarian surgery, radiation, and chemotherapy can decrease or halt ovarian function. Other risk factors for ovarian disruption include smoking, depression, environmental exposure to air pollution, heavy metals, and insecticides. Also, inflammation and oxidative stress. Heavy consumption of caffeine, which would be the equivalent of 5 cups of coffee a day, and alcohol, which would be 2 drinks a day, are associated with decreased fertility. For hormonal factors, an increased prolactin level can cause anovulation and amenorrhea in the same way it does during lactation. Progesterone produced by the ovarian corpus luteum is necessary to mature and maintain the uterine lining. So inadequate progesterone results in a thin endometrial lining unable to nourish an implanted blastocyst. Some tubal and peritoneal factors, tubal patency and motility. So impaired tubal patency and motility result from infections, adhesions, scarring, tumors, or intentional sterilization. One tube could be shorter than the other, or you could be missing a tube. Okay? This is associated with an abnormally developed uterus. Inflammation of the tube or the fimbriated ends resulting from pelvic infections can impair fertility. When infection with purulent discharge heals, then scar tissue adhesions form, blocking or kinking the tube. Adhesions may not prevent the tiny sperm from passing through the tube, but may prevent a larger fertilized egg from completing the journey into the intrauterine cavity. Women who have used barrier contraceptive methods, such as condoms, are more likely to conceive than those who did not, presumably because of the protective effects against tubal damage from STIs. Endometriosis is an inflammatory peritoneal damage caused by endometrial tissue that has migrated out of the uterus and implanted on pelvic organs or connective tissue. Resulting adhesions can result in pelvic distortion. Inflammatory changes are a high risk factor for ovarian dysfunction and blocked tubal transport. We also have some uterine factors like developmental anomalies. These anomalies are actually fairly common. This is when we could have a bicornuate or septate uterus, or even tumors. So tumors of the endometrium and myometrium can impair implantation and normal fetal growth. If a functional uterus can be reconstructed, though, pregnancy may be possible. Vaginal cervical factors. So let's see. In the presence of vaginal or cervical infections, inflammation and white blood cells dramatically reduce the number of viable motile sperm before they enter the cervical canal. The amount of mucus and its physical changes are influenced by the presence of blood, pathogenic bacteria, and irritants such as intrauterine devices or polyps. Severe emotional stress, antibiotic therapy, and diseases such as diabetes diminish the supportive alkalinity of the cervical mucus. Some women develop anti-sperm antibodies, causing the sperm to be clumped within the cervical mucus. This immobilizes the sperm, preventing its migration into the uterus, which prevents fertilization. For male infertility causes, we might have a structural or a hormonal disorder. Any structural or hormonal disorders such as undescended testes, hypospadias, varicocele, low testosterone levels, or previous vasectomy can cause azoospermia, which means that there's no sperm cells produced, or oligospermia, where there's few sperm cells produced. A low sperm count may occur when spermatic fluid is ejaculated retrograde or backwards into the bladder. Damage from mumps, testicular cancer, or pituitary tumors may present as infertility. Nutritional problems, endocrine disorders, genetic disorders, psychologic disorders, and STIs can affect fertility in men. Male obesity can lead to decreased semen quality. Exposure to hazards in the environment such as radiation, heavy metals, air pollution, or insecticides can also affect sperm production. Exposure of the scrotum to high temperatures can cause a decrease in sperm production as well as abnormal sperm production. Cancer treatments can decrease production or quality of sperm. Substance use, medications, and steroids can be factors in androgen-deficient infertility. Cigarette smoking has been associated with a decrease in the number and quality of sperm as well as chromosomal damage. Heroin, methadone, selective serotonin reuptake inhibitors, or your SSRIs, and barbiturates all decrease libido. MAOIs adversely affect spermatogenesis. Some antihypertensives and anti-seizure meds can cause erectile dysfunction. Male infertility declines slowly after the age of 40. For transgender fertility issues, so transgender clients do have several options for fertility. The first thing is that they can choose to cryopreserve either oocytes or sperm prior to gender reassignment. Okay? Additionally, biologic gender fertility could mean that individuals with intact reproductive organs can discontinue their gender reassignment hormone therapy and proceed with fertility care according to their biologic gender. Okay? It is important when intervening with your transgender clients that we have the interprofessional team taking care of this individual. So this is medical, nursing, pharmacologic, and mental health specialists. Okay. It is especially important that staff receives education, particularly sensitivity training, and learns how to be supportive in these situations, and being very careful to use inclusive language, including the client's preference for pronouns. Okay, now we have the assessment of female infertility. So one of the diagnostic tests used is the detection of ovulation. All right, so here, direct proof of ovulation is pregnancy or the retrieval of an ovum from the uterine tube. Indirect proof can be provided by over-the-counter ovulation detection kits. Other indirect detection of ovulation include assessment of the basal body temperature and cervical mucus characteristics, as well as using ultrasound. For hormone analysis, serum prolactin and thyroid levels may be necessary to diagnose the cause of irregular or absent menstrual cycles. Serum progesterone levels may help in diagnosing luteal phase deficiency, which may interfere with maintaining a future pregnancy. Ovarian reserve is established by testing serum follicle stimulating hormone, or FSH, and estradiol, which is E2. High FSH and low E2 may indicate ovarian failure. Okay. Ultrasonography. So we can use transvaginal ultrasound and even MRI to assess pelvic structures for abnormalities such as fibroid tumors and ovarian cysts, or to verify follicular development and maturity, and to assess the thickness of the endometrium around the time of ovulation. Hysterosalpingography is an X-ray that allows visualization of the uterine cavity and the tubes after installation of a radio-opaque contrast material via the cervix. It can sometimes have the therapeutic effect of opening a blocked tube. This test is scheduled 2 to 5 days after menstruation to avoid flushing a potential fertilized ovum out through a uterine tube into the peritoneal cavity. Endometrial blood vessels are closed at this time, and all menstrual debris has been discharged. This decreases the risk of embolism or forcing menstrual debris into the peritoneal cavity. Hysteroscopy uses a flexible scope threaded through the cervix to directly view the uterine cavity. This is the gold standard method for evaluation of fibroids and adhesions that might impair implantation. It's also the most expensive and invasive, so not a first-line assessment method. And laparoscopy. Laparoscopy is useful to view the pelvic structures intraperitoneally outside the uterus, which may reveal endometriosis, pelvic adhesions, tubal occlusion, leiomyomas, or polycystic ovaries. It's indicated for women with symptoms and to rule out endometriosis in long-term infertility of unknown reason. In assessing male infertility, we can do a semen analysis, which is going to assess the sperm number, morphology, and motility. If results are in the fertile range, no further evaluation is necessary. Poor sperm morphology may indicate a need for donor sperm. Semen analysis may reveal leukocytes from genital tract infections or clumping from anti-sperm antibodies of the male. Ultrasonography. So a scrotal ultrasound is used to examine the testes for the presence of varicocele and to identify abnormalities in the scrotum and spermatic cord. Transrectal ultrasound can be used to evaluate the ejaculatory ducts, seminal vesicles, and the vas deferens for obstruction. Okay. Other tests, such as genetic testing, can reveal other reproductive problems, and hormone analysis could be done for testosterone, gonadotropin, FSH, and LH. Infertility care management. All right, so psychosocial is first. Infertility is recognized as a major life stressor that can affect self-esteem, relationships, life goals, and careers. It can cause emotional distress, anger, isolation, sexual dysfunction, and put a strain on the couple's relationship. The stress of infertility and its treatment can exacerbate pre-existing anxiety or depression. Conversely, stress can be a cause of infertility for men and women, making it difficult to identify cause and effect. Same-sex and transgender couples may feel unaccepted and marginalized in healthcare settings, which adds to the stress of infertility treatments. Nurses must be knowledgeable and non-judgmental of the preferences and activities of others. Gender-neutral and inclusive language, as well as pictures and brochures depicting all types of families, including same-sex couples, establishes a tone of respect and safety in the healthcare setting. Also important to assess the support system of the couple. And a history of impaired fertility is a risk factor for pregnancy complications and postpartum depression. Right, so some non-medical lifestyle changes. Loose clothing can improve sperm count. Many commonly used lubricants can diminish sperm motility and quality. Cell phones worn at the belt or hip have been linked to decreased sperm quality. Changes in nutrition and habits may increase fertility for men and women. A well-balanced plant-based diet, exercise, and avoidance of toxins and toxic substances can increase fertility for both partners. Weight normalization, optimal nutrition, and maintaining normoglycemia maximize the chance of conception for males and females. Women who are overweight or obese have a reduced chance of pregnancy following IVF and a significantly greater risk of miscarriage following infertility treatment. Some complementary and alternative measures. So most herbal remedies have not been proven clinically to promote fertility or to be safe in early pregnancy. So we encourage stress management, relaxation, nutritional and exercise counseling, which have increased pregnancy rates in some women. Antioxidant vitamins E and C, selenium, zinc, CoQ10, and ginseng have shown possible beneficial effects for infertility. Acupuncture can decrease anxiety and improve pregnancy rates for women undergoing IVF. For medical treatment, first we can correct any pre-existing factors. So for women, pre-treatment or surgery may be indicated to optimize conditions for conception. Infections are treated with appropriate antimicrobial formulations. Surgery or hysterosalpingogram may be necessary to correct tubal blockage or pelvic distortion. Uterine fibroids may need removal. Removal of endometrial adhesions and implants and draining of hydrosalpinges, which are endometrial fluid pockets, can normalize reproductive function. Okay. Drug therapy may be indicated for male infertility. Problems with the thyroid or adrenal glands are corrected with appropriate medications. Infections are identified and treated promptly. Surgery may be needed to correct varicoceles, blockages, or tumors. FSH, gonadotropins, and clofamine may be used to stimulate spermatogenesis in men with hypogonadism. Ovarian stimulation. If the ovarian reserve is determined to be sufficient, pharmacologic therapy is often directed at stimulating the ovary to produce follicles. The most common ovarian stimulants include selective estrogen receptor modulator, which is clofamine citrate, or gonadotropin. And here are the medications I just mentioned for ovarian stimulation. Clofamine citrate is used for ovulation induction. It binds to estrogen receptors in the pituitary, blocking them from detecting estrogen. The dose is 50 milligrams per day for 5 days, beginning on the 5th day of menses. Side effects include vasomotor flushes, nausea, vomiting, abdominal discomfort, and breast tenderness. Human menopausal gonadotropin, or HMG, is indicated for ovarian follicular growth and maturation. The mechanism of action is direct stimulation of ovarian follicle to induce ovulation. Your dose is 75 international units of FSH, 75 international units of LH, IM or sub-Q for 7 to 12 days, followed by 10,000 international units of HCG. Side effects include ovarian enlargement, hyperstimulation, and multifetal gestation. This takes us to our assisted reproductive technology, also known as ART. Okay, this is the manipulation of eggs and sperm and or embryo. Intrauterine insemination. The sperm can be introduced directly into the uterus. This is the preferred technique for introducing donor sperm. In vitro fertilization, embryo transfer, is used when blockage or inflammatory changes of endometriosis are suspected to impair tubal patency or when tubes have been surgically removed. Ovarian follicles are monitored via ultrasound, removed at maturity, and then fertilization with the sperm occurs in a dish. A micromanipulation technique of the follicle called intracytoplasmic sperm injection makes it possible to achieve fertilization even with few or poor quality sperm by introducing sperm beneath the zona pellucida directly into the egg. Another micromanipulation option is assisted hatching. In some instances, the zona pellucida is thick or tough and the embryo cannot break through or hatch through the coating in the blastocystic phase of development. An infrared laser is used to create a hole so the embryo can break through an implant. Pre-implantation genetic diagnosis can be done on a single cell removed from each embryo after 3 to 4 days. It's a form of early genetic testing that's designed to screen for inherited diseases. Developing embryos free of the disease gene are transferred to the uterus. Because of all the improvements that have been made in this area, no more than a single embryo transfer at a time for women is recommended, except in women over age 37 or with other poor fertility prognoses. Gamete intrafallopian transfer is similar to your in vitro fertilization embryo transfer. GIFT, as it's called, requires women to have at least one normal uterine tube. Ovulation is induced, and the oocytes are aspirated from follicles via laparoscopy. Semen is collected before laparoscopy. The ovum and sperm are then transferred to one uterine tube, permitting natural fertilization and cleavage. Zygote intrafallopian transfer, or ZIFT, is similar to GIFT, except fertilization occurs in vitro and then the zygote is placed in the uterine tube. All right, we also have oocyte donation. Women who have ovarian failure or oophorectomy, who have a genetic defect, or who fail to achieve pregnancy with their own oocytes may be eligible for the use of donor oocytes, or eggs. Egg donation is usually done by women who are younger than 35 and healthy, and who are recruited and paid to undergo ovarian stimulation and egg retrieval. The donor eggs are fertilized in the laboratory with the sperm of the male partner or a donor. The recipient woman undergoes hormonal stimulation to allow development of the uterine lining, and then the embryos are transferred to the uterus. Sperm donation is used when the male partner has absent or unfavorable sperm, the couple has a genetic defect, the male partner has anti-sperm antibodies, or it is a woman without a male partner. Sperm are stored until they have completed 6 months of testing. Embryo donation is used when couples decide that they do not want their frozen embryos and they decide to release them to other infertile couples. Cryopreservation is when sperm, ovarian tissue, eggs, or embryos are cryopreserved for later use. In other words, they are frozen. Surrogate mothers and embryo hosts. So surrogate motherhood can be achieved by 2 methods. The first is for the surrogate mother to be inseminated with semen from the infertile woman's partner and to carry the baby until birth. The baby is then formally adopted by the infertile couple. A less common method is to retrieve an ovum from the infertile woman, fertilize it with her partner's sperm, and place it in the uterus of an embryo host or gestational carrier. Success rates for pregnancy and birth vary widely. Updated and detailed success rates of ART by clinic and procedure can be found at cdc.gov/ART and SART.org, which include a patient predictor calculator for individual odds of success. Risks associated with ovarian stimulation include nausea, fluid retention, or ovarian hyperstimulation, invasive procedures, psychological stress, and general anesthesia. All are risks of ART. ART's rapid advances are associated with many ethical and legal issues, and couples using donated eggs or sperm need to be counseled extensively and cared for regarding the grief over the loss of a biologic link to the child, long-term issues relating to parenting the child conceived through donation include disclosure to the child and family and unknown family health histories. Couples also must be aware of the legal status of donor and surrogates in their states.